With the recent advances, especially in the world of science, patients are slowly moving away from the days of painful invasive surgeries. Heart diseases have been on the rise and open heart surgeries have been the main intervention for a long time. However, primary cardiac practices seem to be changing with the introduction of painless imaging procedures. This is echocardiography.
An ultrasound machine works by transmitting high-frequency acoustic energy to the body through an ultrasound transducer. When the sound waves hit the boundary of soft tissue or bone, they rebound back to the transducer. These reflected sound waves are used by the machine to calculate the distance of the transducer from the tissue, and piece by piece produces an image. Anechoic regions have no significant sound waves reflected and no image is observed, represented by the color black. These are mostly fluids inside a body cavity. Hypoechoic regions are darker gray in color, while hyperechoic regions are brighter gray in color. These different shades of gray usually represent parenchyma. Traditional imaging planes for anatomic structures are transverse or short axis and sagittal or long axis planes. The picture on the monitor is essentially a displayed version of the ultrasound beam that emanates from the transducer face. Structures closest to the transducer are displayed at the top of the image, deemed the near field, while the deeper structures are displayed at the bottom of the screen in the far field. All probes have an indicator that demarcates the leading edge of the beam that corresponds to a mark on the monitor. Echocardiography uses standard 2-dimensional, 3-dimensional, and Doppler ultrasound to create images of the heart. Moreover, it is also useful in estimation of heart functions such as the calculation of the cardiac output, ejection fraction, and diastolic function.
There are three main echocardiographic windows: apical, parasternal, and subcostal views. In this video, the apical 4-chamber and parasternal long-axis view will be discussed. First, the apical 4-chamber view is produced by locating the patient's point of maximal impulse at the 5th intercostal space, left midclavicular line. Once located, the transducer is placed on this side, oriented towards the client's right shoulder. This view enables the visualization of the 4 main chambers of the heart: the left ventricle, the left atrium, the right ventricle, and the right atrium. The vertical line that serves as an intersection between the 4 chambers represents the interventricular and interatrial septa. Furthermore, the opening and closing of the mitral and tricuspid valves are also visible. On the other hand, the parasternal long-axis view is produced by placing the ultrasound transducer on the patient's 3rd or 4th intercostal space, left parasternal line, with the orientation towards the client's left elbow. The left atrium, left ventricle, and the right ventricle are visualized in this window. The interventricular septum and the posterior wall of the left ventricle can also be seen. In addition, the mitral and aortic valves opening and closing are visible from this view.
The cardiac cycle is a sequence of mechanical and electrical events that repeats with every heartbeat. It has 4 phases. Phase 1 is the inflow phase. It includes the events of rapid filling, diastasis, and atrial contraction. When the intraatrial pressure overcomes the decreasing intraventricular pressure, the mitral valve opens. This will allow blood to rush from the left atrium to the left ventricle. A period of decreased filling or diastasis follows. Atrial contraction causes a slight increased intraatrial pressure that minimally contributes to stroke volume by squeezing out blood from the left atrium. Let's take a look at the ultrasound clip to see the atrioventricular valves open and the walls of the ventricles expand. Phase 2, the period of isovolumetric contraction, is marked by ventricular contraction and a rise in intraventricular pressure. The mitral valve closes at the point when the intraventricular pressure exceeds that of the intraatrial pressure. At this phase, the aortic valve remains closed. Phase 3 is the ejection or outflow phase. With the continued increase of intraventricular pressure from the previous phase, the aortic valve opens as the aortic pressure is exceeded. Blood then flows rapidly from the left ventricle to the aorta. As the ventricle contracts, ventricular pressure continues to rise. It is followed by a rapid increase in aortic pressure marked by slow ejection of blood from the ventricles. Let's try to see the opening of the semilunar valves as the contraction of the ventricles pump the blood to the circulation. The last phase is isovolumetric relaxation. It begins when left ventricular pressure falls below the aortic pressure and the aortic valve closes. There is no blood flow during this phase because both the mitral and aortic valves are closed. It is then followed by another inflow phase, which marks the beginning of a new cycle. Phase 4 and Phase 1 correspond to the period of ventricular relaxation, termed as diastole, while Phases 2 and 3 correspond to the period of ventricular contraction, termed as systole. By now, we are already aware that the apical view shows all the 4 chambers of the heart. It is the preferred view of most cardiologists because it shows the synergy of the chambers to one another. The patient is usually placed in a left decubitus position because it moves the heart nearer to the probe and prevents the lung from obstructing the view, hence a better image. Let's take a look at an interesting video clip of a patient who presented with acute shortness of breath. We see here the left ventricle and the right ventricle, but notice the black ring or anechoic region surrounding the chambers. We learned earlier that anechoic regions usually represent fluids in body cavities. This is a sign of pericardial effusion, which is an abnormal accumulation of fluid in the pericardial cavity. You will notice the heart swinging back and forth in all the pericardial effusion. This gives rise to a phenomenon known as electrical alternance, or different sizes of QRS in the EKG. Let's look specifically at the right ventricle. Notice that it caves in from diastole due to the high pressure in the pericardial sac. This is indicative of advanced cardiac tamponade. If we see this in a patient's echocardiogram, we're gonna need to do a stat pericardiocentesis procedure. That concludes our mtap. Happy imaging, everyone!
Yes,